Hello and welcome to week 6. We are almost on the way to the finish line. I hope you are all enjoying this course and learning a lot. And again, as always, please reach out if you need any help or you need any suggestions for the topic each week with regards to your assignment. I can always do one-on-one Zooms with you if you need clarification on anything. With that said, I'm going to do a review, very cursory review. You've all been through anatomy, but I'm still going to review the cardiovascular system and a little bit on the lymphatic system. So we're going to go over normal and abnormal and then provide some ideas in terms of what you can write about with respect to the assignment pathophysiology of the cardiovascular and lymphatic. What I don't want is 25 assignments on myocardial infarction, heart attack. Please try to be a little bit more esoteric. Pick something, I don't know, mitral valve regurgitation, tetralogy of Fallot. There's so many things, aortic stenosis. I can't even think right now, but if you want to pick something that's different other than the norm, yes, we know that most people, when they have cardiovascular issues, succumb to an MI. I need you to go a little bit beyond that and find something that is less common, because chances are in your medical career, you will come across something and go, well, I never heard of that. So research something that you think is rare, because you never know. It's always happened to me when I was in practice. So that's my advice to you. So now I'm going to move through the module, as I always do, just to introduce to you what you're going to go over. And I'll do a little micro learning lesson on cardiovascular with the actual content that's here, because I examined it very, very much. And, you know, I could go over my own videos, which I'll probably post, and maybe some PowerPoints, but honestly, everything that you need to know is all created here. The course content is excellent, and everything that you need to learn about cardiovascular, normal and abnormal, is in this, I would say, succinct content, Cliff Notes version, so that you can get a grasp of normal anatomy and then pick out the pathophysiology, because you've already been through the cardiovascular system in A&P2. So again, what are you going to learn here in pathophysiology that's different from A&P2? You're going to learn the abnormal diseases that occur in the cardiovascular system, and there are many. So first, we're going to go over and revisit and circle back to the cardiovascular system, which you should have a strong foundation already, but I will build it again if there's some cobwebs in the brain, if you haven't seen it in a while. So we're going to describe the anatomy of it and the function. We're going to go over the blood flow as well as the cardiac conduction system, and how does that relate to the EKG, PQRST waves. And then we're going to jump right into lymphatic system and understand why the lymphatic system is really important. Other than that, it picks up excess fluid from the vascular system, it also happens to carry out your immune system demand, because the white blood cells travel through the lymphatic system, and there are lymph nodes where it's kind of like tent cities for the white blood cells to reside. And then the thymus gland is where the T cells will mature. So we're going to go over that. And pretty much after that, we're going to understand how the cardiovascular system differs amongst different ethnicities, based, of course, on diet, race as well. Some are more have a higher predilection to high cholesterol and heart disease. And of course, your age group puts you at risk for cardiovascular disease. And note also that estrogen is protective to women. Your menstrual cycle is protective in terms of cardiovascular protection. But as soon as you start to hit menopause, you start to equalize the risk to cardiovascular complications. And then by the time you're in your 65 to 70, you're pretty much the same risk as the male. Because as I said, having your estrogen levels and other sex hormones that are involved in your menstrual cycle optimal is what also protects you from heart disease. It is when there's an off balance in the hormones that can, or drop in the hormones that can increase the risk of cardiovascular disease in women. I mention that because a lot of people really just focus on the male gender because that's what we see a lot in the ER. But honestly, there's a lot of misdiagnosis or just not diagnosing what the female has, because the typical chest pain is not the same presentation as in the male. The male will have chest pain or epigastric pain. It might feel like reflux and it might radiate to the left arm. In women, it's completely different. They might have some sharp stabbing pain in the left scapular region, or it kind of spreads out across the upper back and it feels like indigestion as well. And it'll be more diffuse chest pain, and it typically does not radiate to the left arm in the female. So these are things that I'm mentioning because you'll be out there in the field, wherever you'll be working, OR, ER, ICU, floor, you need to know these things. So let's move on to the next topic here, which is going to be a systematic review of the cardiovascular system, which I'm going to give you the big picture of how blood flows through the heart. So before I even go to the image, I'm going to describe to you how blood flows through the heart. And I'm not going to do it the standard baby form where it's like, okay, it goes through the right atrium, right ventricle, pulmonary trunk, lungs, back. No, we're not doing that. I want you to learn it the way it actually works, because it's a double pump, and the double pump is going to work simultaneously. The left atrium and the right atrium are contracting at the same time. The left atrium and the right atrium are going to pump the remainder of that blood, which starts off that whole systolic phase. Diastolic phase is the filling phase. So let's get that terminology straight. So let's go over that. So systolic phase is the contraction phase. Diastolic phase is the relaxation phase, where the blood is just naturally filling into the atria and the ventricles, because both the tricuspid on the right side and the bicuspid, aka mitral valve, are open. And that is the diastolic phase, the blood filling phase. Blood is returning to the right atrium via the inferior vena cava, which is deoxygenated blood that has been drained from the lower extremity pelvis and coming up inferior vena cava into the posterior aspect of the heart and entering the right atrium. Simultaneously, you've got blood coming in from the superior vena cava, and this blood is the blood drained from the head, neck, and superior limb, the arms, entering the right atrium simultaneously, filling. And it doesn't stop there. 80% of that blood is entering the right atrium and going into the right ventricle while the valve is open. What valve? The tricuspid. So 80% of that blood is filling into the right atrium and the right ventricle. But wait, there's more. Simultaneously, at the same time, you got to be thinking double, all right, because it's a double pump. Simultaneously, the blood that is oxygenated is returning from the lungs, newly oxygenated blood. It's coming from the right lung and the left lung via that pulmonary circulation. Unlike systemic circulation, we learned that in systemic circulation, the arteries are oxygenated, therefore they're red, and blood is being carried out away from the body, away from the heart towards the rest of the body. And veins are deoxygenated blood, like inferior and superior vena cava, coming back to the heart, systemic veins coming back to the heart, blue, right? They're colored blue typically, in diagrams. And so that represents deoxygenated blood via the veins. Veins carry deoxygenated blood in systemic circulation. But that's not the case here because we're talking about pulmonary circulation. So therefore, blood that is returning from the lungs, returning to the heart, in this case is oxygenated, and in this case, they're veins, right? Because veins return, right? And arteries take away, right? So the pulmonary veins are returning blood to the heart, but it's pulmonary circulation. And unlike systemic circulation, where the veins carry deoxygenated blood, i.e. inferior and superior vena cava, right side of the heart, right? Because they're systemic veins. These are pulmonary veins. That's what they're called, pulmonary veins, from the pulmonary circuit, bringing oxygenated blood from the lungs because it needs to go throughout the rest of the body. But how does it get throughout the rest of the body? It needs to move through the left atrium and the left ventricle. So during this diastolic phase, blood is entering both the right atrium and the left atrium, the right ventricle and the left ventricle. Why? Because the valves are open. 80% of that blood is trickling in. That's the diastolic phase. And then the remainder of the blood, which is 20%, remember that number, is going to be actively pumped. It's a double pump. What do we mean? Both the right and the left atria contract. But how does it contract? It'll only contract because there is a depolarization event. It's an electrical charge that changes. And just like we learned in A&P1 about muscle contraction, what we have here is a surge of the sodium, potassium, and calcium ion and change in the gated ion channels. And make the long story short, because I'm not going to go and jump into the electrophysiology of that, because that's another 1 hour lecture just on that. But depolarization occurs. In other words, we go from a negative 90 to a positive 30. We've got a positive number and we've got a depolarization event. So that depolarization starts at a node called the SA node, sinoatrial node, found in the wall of the right atrium. And that electrical charge depolarizes all those cardiac muscles that are involuntary and have the intercalated discs, which make everything happen in synchrony, all right? And so it goes from the SA node to the AV node, which is still in the wall of the right atrium, but closer to the interatrial septum. And then that electrical charge spreads across to the left atrium, so that by the time the depolarization event occurs in both the right atrium and the left atrium, that depolarization is going to initiate contraction. Contraction happens simultaneously in both right and left atrium, and the remaining 20% of blood is now pumped into the ventricles. Now what? The ventricles have 100% of the blood in there. We don't want backflow. If there is backflow, then we have mitral valve regurgitation, which is the most common valvular pathology. Okay. And why not in the tricuspid? Because it has 3 leaflets and it's less likely to be damaged. But yes, the bicuspid typically gets damaged over age. It could get damaged from a streptococcal infection. It could be congenital. You can be born with it, right? So anyway, all the blood has to remain in the ventricles. So what has to happen? The first heart sound, S1 is what we call it. The first heart sound is called S1, and that's closure of the atrioventricular valves. What does that mean? That means the right side has the tricuspid, the left side has the bicuspid, also known as mitral valve, right? And they close. That first heart sound of the ba-bum, ba-bum, the ba of the ba-bum is closure of the atrioventricular valves. Now what? The next step is you got 100% of the blood in the ventricles, which means what? It means that this increases the ventricular pressure. And remember, we didn't stop at the AV node. The electrical impulse continues down the interatrial septum, down the interventricular septum, and we're going into the Purkinje fibers. So SA node, AV node, and then from there, eventually spreading into the Purkinje fibers along the ventricular walls, initiating none other than contraction there as well. So that increase in interventricular pressure and the spread of the electrical impulse, the conduction, will spread to the ventricles via the Purkinje fibers and initiate the muscles in the ventricles to contract. Great. What happens? Well, depolarization initiates contraction, and then the biggest event happens, the contraction of the ventricles. And the pressure is so high that it forces the valves open. Which valves? Well, now we're talking on the right side, the pulmonary valve, and on the left side, near the left ventricle, the aortic valve. They get forced open because of the contraction, and the blood goes swoosh, so that, let me not spill my water. The blood goes swoosh, and so from the left ventricle, it crosses over into the aortic arch, and from the right ventricle, it goes up the pulmonary trunk, a big, big pulmonary trunk, which, remember, it's deoxygenated blood in the right ventricle, oxygenated blood in the left ventricle. So all this blood is pushed out, contraction, ejection phase is what we call it. And the ejection phase is the ejection of the blood from the ventricles into the great vessels. What are the great vessels? The great vessel on the right side is the pulmonary trunk. The great vessel on the left ventricle that leads to blood throughout the rest of the body is the aortic arch. Right side, pulmonary trunk, left side, aortic arch. Now, there's something called a dicrotic notch, which is a slight backflow of blood to signal to the valves to close. And that's exactly what happens. Once the blood is pumped or ejected into the pulmonary trunk and aortic arch, there's a slight backflow, which then closes the aortic valve and the pulmonary valve. What does that signal? That's the second heart sound. That's the second heart sound, S2. So it's the bum of the pum, right? So the second heart sound. And so that terminates that systolic phase. So when does the systolic phase actually start? The systolic phase starts as soon as the atria contract and ends as soon as the ventricles have contracted and the blood has departed the ventricles, and now we've got valve closure. As soon as S2 valve closure has happened, we're now back into the diastolic phase. The valves open. Which valves open again? The tricuspid on the right side and the bicuspid on the left side. All right, so the valves open again, and now we're back into that diastolic phase, and it continues like this. Diastolic phase is the filling phase, and yet again we have blood returning from the lungs, oxygenated, from the body, deoxygenated, back into the right side of the heart, oxygenated blood into the left side of the heart, and a cycle continues for as long as you're alive. And that is the big picture. So I just spent 10 minutes talking about that little paragraph. So let's go to the image so I can show you. And I'm going to use my annotation. Let me move this up. Okay, so deoxygenated blood, so blood that is low in oxygen, is coming in via the inferior and superior vena cava. Simultaneously, we've got two pulmonary veins coming from the left lung. I'm going to put LL, and you can't see it in this image, but there's two pulmonary veins coming from the right lung. All right, so we're going in like this through the back of the heart posteriorly, and we're going in like this through the back of the heart posteriorly from the left lung and the right lung. So oxygenated blood, and you see it's red, arrow versus blue. Oxygenated blood is coming, newly oxygenated blood is coming from the left lung and the right lung. So you got two pulmonary veins from the right lung, two pulmonary veins from the left lung entering the left atrium. What do you have going on the right side simultaneously? deoxygenated blood coming from the superior vena cava and the inferior vena cava into the right atrium. Okay, now remember, the right atrium and the left atrium in the diastolic phase, 80% of that blood is naturally flowing into the ventricles. Okay, so on the left side, it's oxygenated blood. Therefore, I drew a red arrow. And then on the right side, I drew a blue arrow. So 80% of that is going to be just flowing in naturally during this open phase, diastolic phase. Open, by what I mean by open is that the valves are open. And then what do we have? The SA node, which is not drawn in this image, and the AV node initiate a conduction, electrical change, causing depolarization. And that depolarization event is going to spread across the right and the left atrium, going down the interventricular septum and then up the Purkinje fibers. Okay, but that initial depolarization in the atria is going to cause atrial contraction of both right and left atrium, so that the remaining 20% of blood is now pumped into the ventricles. Then what? Then S1. S1 is closure of the tricuspid and the bicuspid valve. Okay, so closure of the tricuspid and the bicuspid valve. These are called the interventricular, the AV valves, interventricular valves. Bicuspid is also known as the mitral valve, not just bicuspid, but the tricuspid only has one name. Okay, so that is the beginning of the contraction phase, which is the systolic phase, where the right and left atria will contract at the same time. And the first heart sound is closure of the AV valves, which is tricuspid and mitral. Now, let me clear all the drawings. 100% of the blood is in both the right ventricle and left ventricle. And remember what I said, the spread of the impulse, cardiac impulse, is now going up the Purkinje fibers. Depolarization occurs and followed by ventricular contraction. Now, this is me going like this, bifurcating. Why? Because that's exactly what's happening here. Let me clear the drawings. If you look on this side, let me draw this in yellow. We've got blood coming out this way into the aorta, into the aortic arch. You see that? Blood is coming out this way via this aortic valve. On this side, blood is coming out and it's pumped out, right? It's ejection phase from the right ventricle via the pulmonary valve, which is now forced open right here, and going out via the pulmonary trunk, and eventually one vessel to the right lung and one vessel to the left lung. What is that vessel called? The right and left pulmonary artery. And super important for you to know, I don't know why it's not drawn here. You should know that one pulmonary artery, not two. You got two pulmonary veins, but only one pulmonary artery goes to the left lung. And then you've got, believe it or not, underneath this aortic arch, okay, underneath this aortic arch and behind the superior vena cava is the right pulmonary artery, RPL, RPA, right pulmonary artery going to the right lung. Okay, so you got deoxygenated blood via the right pulmonary artery, deoxygenated blood via the left pulmonary artery. Both are going to the lung. Why do I need you to know the pulmonary arteries? Because this is typically where patients get a PE. Pulmonary embolus happens in the pulmonary arteries, and therefore now there's no oxygenation taking place because the clot is causing that, and a person can die because now there's no more oxygenation. Then eventually the heart will stop. All right, so that is the deal. So now we're not done yet. Blood is pumped out of the pulmonary trunk to the right and left pulmonary arteries going to the right and left lung. Blood is pumped out of the left ventricle into the aortic arch, and from the aortic arch down the thoracic aorta, abdominal aorta, and then many, many highway exits across all the arteries, arterioles, capillaries, disseminating oxygenated blood to all tissues of the body and all organs. And these three here these three amigos are going to go become the common carotid, internal carotid, brachiocephalic. All that is going to be happening because we need oxygenated blood going to the neck and head, because the brain obviously needs a lot of oxygen. Okay. So once the closure of the pulmonary valve and the aortic valve happens, that's S2. So now that the blood is pumped into the aortic arch and throughout the rest of the body, and the right and left pulmonary artery going to the lungs, there's a little backflow of extra blood that's kind of backflowing, and that's going to cause the dicrotic notch seen on image. And therefore, at that time, the S2 heart sound is going to occur, which is where I'm going to go next with imaging and EKG, electrocardiogram. So now that we have S2 happening, the second heart sound, this is the finite ending of the systolic phase, and we move back to the diastolic where blood is filling again. So I do hope that that review helped. I know I was pretty lengthy on explaining that, but now I'm going to jump into the cardiac cycle. And a lot of people don't really talk about the cardiac cycle together with the blood flow. I did. I told you that 80 and 20. Now, here they talk about 70. I like the 80-20 rule because it's easy to remember. 80% of the blood is flowing in naturally, and then the remaining 20% is pumped in. All right. So that's why it says here actually about 70%. For the purposes of the test, because it's written here as 70%, that's fine. Keep that number. All right, now the heart sounds, I already told you, S1, S2. Let me tell you about this third heart sound can be heard. This sound is the result of ventricular filling and can be heard in children and athletes. Okay, just so you know. But if someone is elderly, it could be a sign of congestive heart failure. The fourth heart sound occurs just before S1, and it's not often heard. This is an abnormal sound, and this is forceful contraction of the atria, forcefully pushing blood against a failing ventricle. Okay, so this again is not normal. And then another thing that you should know is that between S1 and S2 is the ventricular systole. In other words, that's, as I mentioned before in explaining the cardiac cycle and blood flow through the heart, by the time the atria is contracting, and then we got closure of the AV valve, and then closure of the pulmonary and aortic valve, right? Those are called the semilunar valves. So closure of the AV valves and the semilunar valves. That whole cardiac cycle is the systolic phase. As soon as S2 happens, then we're not in ventricular systole anymore. Okay. So the period between S2, like right after S2, second heart sound, and the beginning of the first heart sound, that's diastole. And I hope that's super clear. I'm going to annotate that because that's a big question that everyone gets wrong on tests, and I don't want you to be that person. Okay. Now, moving on. We all know about cardiac contraction. I'm going to hit that, you know, with other videos that you'll see in this module. I really don't want to go into that because that's a whole other lecture. And I'm supposed to be doing micro lecture lessons here, and you guys can do the rest on your own, unless if you have issues, then of course you're going to contact me and I can teach you that aspect, whatever you need clarification on. This I already explained to you the cardiac cycle, and I want you to read through it on your own. And here's the image, as I told you about the SA node, the AV node, and then the cardiac impulse spreads down the interventricular septum. And these are called left and right bundle branches, but suffice to say, they break up into these Purkinje fibers. So these Purkinje fibers is what is going to initiate muscular contraction. All right. And now the last thing I want to go over, which is super, super important, at least for cardiovascular, then I'm going to jump into the lymphatic system. The P wave on the PQRST. So this is an EKG. This is what's measured, and it's a sample of whether the heart is working or not properly with respect to the cardiac conduction system. If there's a PR, integral, segment that's elongated, that's abnormal. It's first or second degree AV block. If there's a T wave inversion, that's a sign that you've had a myocardial infarction. If there's a sawtooth appearance, then we've got atrial fibrillation. We've got different kinds of views of EKGs that represent pathology. And I encourage you to do atrial fibrillation or atrial flutter. What is ventricular fibrillation? There's so many different types of arrhythmias. There's not just one, there's many. Parkinson's syndrome. Go ahead and explore it. Give me something that's exciting to read about, not MI the entire time, because if I have to read through 25 MIs, I'm going to get bored to death. So go and start searching some of the arrhythmias. But let me go over the normal PQRST and what it represents. So the P wave represents depolarization of the atria, right? So I already told you that the right and the left atrium depolarized thanks to the SA node and the AV node. Once depolarization is complete, we've got this flat line here. This flat line represents that depolarization is complete. So the next step right now, what's happening during this flat line is the initiation of contraction of the atria. Then what? Depolarization of the ventricles, which represents QRS. This big sawtooth appearance represents the QRS complex. And this is when the actual powerful depolarization of the ventricles is occurring. Ventricular depolarization is complete. That's the ST segment. Nothing's happening here on EKG, but physiologically something is happening, the ventricular contraction, because what happens first before you contract? Depolarization. So this is depolarization, then ventricular contraction is representative of the ST segment. And then when we go back to the normal resting membrane potential of the ventricles, that's repolarization back to normal, and that's the T wave. And by the way, lots of people don't talk about this. The QRS is not just depolarization of the ventricles. That is true. It is depolarization of the ventricles. But at the same time, just so you know, simultaneously, at the same time, the atria are repolarizing, and that's the QRS. Okay, so P wave is atria depolarize. And I say atria, right, because it represents both right and left atrium. I'm going to put it shorthand. And then T wave represents ventricles repolarize. I'm just going to put repolarize. This segment here means that ventricular depolarization complete, and we have contraction. And then this segment here represents depolarization of the atria complete. Okay, so I hope that this is super, super clear, because it is super important for you to understand before you start studying the pathophysiology. You got to understand the normal electrophysiology of the heart. You've got to understand the blood flow in synchrony with the cardiac cycle, because that's how the body works. Unfortunately, when we first learn about the heart in A&P 2, you're kind of like, it's the first time you're learning it, and you're just at the beginner level. So now you're not at beginner level, you're intermediate, almost advanced, where we can synthesize the two concepts together, the anatomy, the blood flow, and the electrophysiology together, and how it all works to be represented on an EKG electrocardiogram. And then what is an echocardiogram? Is it's actually looking at the anatomy of the heart and watching the blood flow in real time. And you can find any heart valve issue with the echocardiogram. All right, so now I think that's my lesson. You can go over what systolic volume is and how you calculate that. It's end diastolic minus end systolic volume. Read through that. Read through the nervous system and how it relates to cardiac. Read through control of blood pressure. You've got to understand what MAP is, mean arterial pressure, and how you calculate it is stroke volume times heart rate times peripheral resistance. So read through that and read through the renin and I can't talk. Renin, angiotensin, aldosterone system, because how much blood is pumping through is going to increase your blood pressure, which therefore increases the heart rate. But if we can pump out through the urinary system, if we can get rid of some fluid, then the blood pressure naturally goes down. So there's ways of doing it via the ions and controlling through hormones. And we can also bring the blood pressure up again through this system. So angiotensinogen is going to be converted to angiotensin 1 to angiotensin 2, thanks to ACE is a place in the lungs. But ACE comes from the lungs and it converts angiotensin 1 to angiotensin 2. Look at this flow chart and watch what happens with angiotensin 2 is going to have a multifactorial effect on blood pressure. Why? Angiotensin 2 is a potent vasoconstrictor. So it's going to increase your sympathetic activity, turning on the fight or flight response, epinephrine. It's going to cause the sodium potassium ion system to change and alter so that we're actually holding on to sodium. Water is reabsorbed because water follows solute, right? And if water is reabsorbed into the system instead of excreted out into the urine, your blood volume goes up, blood pressure goes up. It also has an influence on the aldosterone secretion from the adrenal gland. So aldosterone from the adrenal gland and the which is in the cortex of the adrenal gland. And so what does aldosterone do? That is also going to cause that whole sodium potassium reabsorption of water. Okay, and it's all interrelated to the angiotensin. All right, because angiotensin 2 is going to influence the release of aldosterone. In addition, angiotensin is going to cause vasoconstriction. Think of like the water hose, right? So vasoconstriction is going to bring the blood pressure up. And if it brings the blood pressure up, it's also going to cause increase in the heart rate. And in addition, angiotensin 2 is going to influence the release from the posterior pituitary ADH. And antidiuretic hormone is going to affect the collecting duct in the tubular system, the nephron system of the kidney, and also the distal convoluted tubule, as well as the collecting duct, where ADH is going to influence the reabsorption of water, again, because of the sodium thing. Water follows solute. And so now we're going to hold on to water, retain more water instead of secreting it out, I should say, via the urinary system. And so we're holding on, retaining more water, blood volume goes up, blood pressure goes up, and your heart rate goes up. Okay. Now, what happens if the heart is detecting all of this going on? It's going to want to lower its effort. So it's going to release this natural hormone that it releases. It's called atrial natriuretic hormone, ANH, and it is released. It's a peptide from the walls of the atria. And why is it released? Only when the atria is stretched. Why is it stretched? Because there's more blood volume. Why? Because of the blood pressure going up, and all because of this angiotensin aldosterone system. So in order to reverse that whole situation, we've got ANH that is released, and it's going to release and target the kidneys to eliminate the sodium. If we eliminate sodium, then water follows. So we're going to pee more, we're going to urinate more, we're going to diminish the blood volume, and therefore decrease the blood pressure, and therefore decrease the heart rate and heart effort. And that's the way the heart can control effort and cardiac stress. ADH, as I said, is released by the posterior pituitary, and it is going to control this whole aspect of how much of the fluid is retained or conserved, so that less urine is produced. And I will tell you this, it's an interesting note that you need to know. Why is coffee and alcohol a diuretic? Because it suppresses ADH in the posterior pituitary. And this is why people have hangovers after too much drinking, because they urinate out more, because again, ADH is suppressed, so they urinate more. If ADH is functioning, then ADH is going to control and retain the sodium, and water will follow. Okay. All right, so peripheral resistance all has to do with blood volume, and blood volume all has to do with fluid, and fluid all has to do with osmosis. Therefore, salt and water is the key to regulating your blood pressure, and that's why we have diuretics for people who have uncontrolled hypertension, and other things that we do to lower the heart rate, such as beta blockers, which is going to lower the heart rate so that there's less cardiac effort and we could lower the blood pressure. All right, moving on. I'm going to briefly move in through all these little pathologies that are very common, and I'm going to tell you right now, move past this and find some more esoteric things to talk about. But pericarditis is inflammation of the lining along the heart. We have the visceral pericardium and the parietal pericardium. The visceral pericardium is the connective tissue lining the heart. And pericarditis can cause sharp pain that mimics, myocardial infarction, and it produces a pericardial rub sound. You can diagnose it, including with a stethoscope, as well as obviously an EKG and blood tests. Blood BUN and C-reactive protein is, pathognomonic for this pathology. Also looking at an ultrasound or even an MRI can diagnose it. Pericardial tamponade is an emergency. This is when fluid builds up in the pericardial area, and it can cause heart failure. This is commonly caused by trauma, cancer, inflammation, kidney failure, radiation treatment, and post-op surgical intervention for something else. The rapid breathing, weak pulse, anxiety, dizziness, fainting, low blood pressure, hypotension, right? Chest pain radiating to the neck, shoulders, and back. This can all be pericardial tamponade. Hypertrophic cardiomyopathy. This can be a thickening of the ventricles. This can actually be genetic or induced over the years, and will cause arrhythmias, palpitations. Different kinds of abnormal EKGs will be seen, and again can be diagnosed with a cardiac MRI. You'll see a lot of this in the elderly. Congestive heart failure will be shortness of breath on exertion, fatigue, swelling in the abdomen, inability to perform any activity, coughing with pink bloody sputum, fluid retention, increased urination, and chest pain. Heart failure can be diagnosed with chest x-ray, EKG, and echocardiogram, and also assess the levels of atrial natriuretic peptide, ANH, right? And then getting a CAT scan and MRI to really evaluate the size of the heart, especially the ventricles. Heart failure is going to lead to left-sided heart failure, or you can have right-sided heart failure. So left-sided heart failure affects the filling of the ventricles, and the pumping of the ventricles. All right, so it's the systolic heart failure. And in diastolic heart failure, the stiffness of the ventricular wall is going to interfere with the ability to even relax. So the amount of blood entering the ventricle is going to be altered. And then in systolic heart failure, the ventricular wall is so damaged that it just can't pump the blood out of the ventricles. So it has a decreased ejection fraction. So you're not ejecting all the blood fills, the ventricles enlarge, leading to very large ventricles that have to compensate for the reduced inability to pump the blood efficiently. Now, what about right-sided heart failure? This is when the ventricle is so damaged in comparison to the left that the left-sided heart failure causes an increase in pressure in the right side of the heart. And so this increased pressure can damage the right side of the heart, causing the blood to back up into the abdomen and extremities, and that will lead to eventual death. More commonly, you're going to see coronary artery disease thanks to eating McDonald's. If you eat every day McDonald's, now I'm picking on McDonald's, but I mean, you know, fast food and anything that's really bad that builds up plaque. So, you know, keep your cholesterol down, exercise, cardiac exercise helps, and, you know, keeping a healthy weight. Anything that is between 60 and 100 beats, that's normal, but anything above 100 is considered tachycardia. And then in addition, you can have different types of arrhythmias. 2 sentences here doesn't do it justice. If you look up arrhythmias and you look up an assignment that you want to do on arrhythmia, you're going to find a whole plethora of different types of rhythms that you're going to see on EKG that are abnormal and what causes them, the etiologies. So make sure if you're interested in arrhythmias, if something really piques your interest, write about that. Supraventricular tachycardia is also known as paroxysmal supraventricular tachycardia. And it is a rapid regular rhythm between 150 and 250. And it could be very scary when you get that high, but people get controlled with cardiac medications to diminish the cardiac rate. All right, ventricular tachycardia. This one is a little bit scary because this can turn into something deadly. Because, you know, ventricular tachycardia could end up into VFib. Bradycardia is too slow, ventricular tachycardia too fast, atrioventricular node reentry tachycardia. So read about these and view in the biodigital human models, which is amazing. You're going to view the atrial fibrillation, which is also amazing. In fact, if I had more, well, let's open it up and let me show it to you. So with an arrhythmia, it's an abnormal heartbeat caused by the defects of the cardiac conduction system. And so the atrial fibrillation is a common type of arrhythmia in which the atria quiver, as you can see here, they're quivering, right? Or flutter out of rhythm with, and so it's not in rhythm with the S1, S2. So they're not effectively pumping the blood into the ventricles. This causes stasis or stagnant blood in the atria, which can cause clotting and various clotting and even a PE. The blood clots can break loose and travel to vessels to the brain, causing stroke or putting patients into risks of stroke. All right. So what else do I want to show you? Let's do this. There we go. Now you can really see the conduction system and how it's not working properly. All right, so take a look at all this. It's really amazing. Let me go back to where we were. And I love the biodigital human because you can really see everything 3D a lot better than me just explaining it here. So this is VFib. I want you to see VFib because this is pretty bad. This is what happens in VFib. Completely out of whack, as you can see. All right, and now watch this. Okay, so very erratic. So VFib can lead to death. You can't sustain that rhythm for very long. Now AFib, you can sustain for a long time if it's been diagnosed. Hate to do this, but I'm going to give my father an example because I'm going through this saga right now. So we here in Florida had Hurricane Ian. September 25th is we got the warning, and then a couple days later it hit. So right after that, my dad went into AFib. I guess he was he's 85. He was moving with my son the garden plants, and he went into AFib. He's been in AFib since. We was hospitalized, and they did all these different medications to try to control the AFib and bring it back into normal sinus rhythm. It has not worked. He's obviously anticoagulated so that he doesn't clot, and he's been in AFib. It is now December, and he's been in AFib since end of September. So now that we know that, December 29th, he's going to get cardioverted, which means they shock the heart back into normal sinus rhythm. And then they're going to do cardiac catheterization to look for any clots in the atria, get rid of that, and then eventually fix what needs to be fixed, which is basically he has mitral valve regurgitation. The valves are so damaged that they can't even be repaired. They need to be replaced. So a simple thing that is congenital, like mitral valve regurgitation, may not be even an issue when you're an athlete in your 20s, but when you're in your 80s, it will finally get damaged. So if anyone wants to do AFib and how it relates to atrial regurgitation, go for it, because I learned a whole lot more than what I thought I knew, because I'm in constant communication now for the last 2 months with the cardiologist on this. So that's everything you need to know about cardiology, which I think is an amazing topic. As you could see, I spent a lot of time on it because I love teaching it. So therefore, I really want you to go over all these videos and soak in as much as you can, because honestly, this is one of the central systems that you really have to know if you're going to be in the medical field. You have to. And it's, even if you're not going to be in the cardiac unit, you need to know this. It's super important. Okay. All right. Now, not to downplay lymphatic system, I'm going to go over lymphatic very quickly, maybe a 5-10 minute thing. What are you going to need to review on this? This is going to be easy peasy compared to the heart. You're going to learn about the lymph nodes, learn about the path, the circulatory system that is known as the lymphatic system. So learn the names. And the patches are kind of like, it's lymphoid tissue, but they're not lymph nodes. And they are also going to have a conglomeration of white blood cells to fight off any potential infections. Okay. So read through this and watch the videos, and then boom, we're going to do the assignment. So I'm going to end this video with explaining the assignment as I always do each week. And hopefully, I don't know if these videos help. Give me some feedback. Let me know. I don't want to waste your time. If you're not watching it, I don't know. I hope you are. And I do hope that you don't think that you're on your own with learning this, because you're not. If you need me, please reach out, Canvas inbox, and I would be more than happy to have a conversation about any pathophysiology that you want to talk about, or the normal anatomy and physiology of something that is maybe not clear to you. Okay. All right. So let's go over this assignment so you all get good grades. You know me, as long as you satisfy the rubric and you do everything you're supposed to do with respect to your topic, you're golden. So what do you need to do here? Complete part 1, list names and descriptions of the different types of hypertension. All right, so look it up. It's not hard to do. Identify the major risk factors associated with each type of hypertension. Describe how each hypertension is diagnosed. Describe the treatments for the disorder. Explain how hypertension affects patients of varying ages and ethnic groups. Because as I mentioned, some ethnic groups are more susceptible to getting hypertension than others. It is something genetic. Now, what about part 2? Part 2 is description of lymphedema. How do we get lymphedema? All right, we can get bilateral lymphedema. We can get unilateral lymphedema. Describe it in detail. Describe the signs and symptoms for each type of lymphedema. As I said, you can get bilateral or unilateral. Describe the treatments for each type of lymphedema. Your assignment must be a minimum of 300. Now, I will tell you right now, 300 is the magical word to, amount of words to pass. It doesn't mean that it's going to satisfy all these bullets. So in order for you to satisfy all these bullets, I can assure you it's going to be more than 300, as I say every single week. Make sure more is better. All right. Spend time, put in the work, get the details in, and elaborate. Okay. Because if you do, you get the full points. Don't miss anything. Make sure you fill those bullet points. Okay. APA citations. Here's the thing. As I mentioned last week, we've had this recurrent, theme, and I get, in Canvas inbox, these emails, and also inbox Canvas saying, You know, my number should be 20, but every time I put in my references, it's over 20. So with that said, put your references in the comments section of the assignment, and I will see it, and I will mark it within the rubric that you did it. Okay. So this way, the turn it in is not going to tag the reference. Now, you're still going to be tagged on the in-text citations. You can't help that. So my suggestion is minimal. I love it. Personally, I like doing in-text citations, but keep it to 1 and try to elaborate with your own words as much as possible. I know it's hard because technical terms, medical knowledge is going to be used across the board. Okay, so that word is going to pop up a lot. Turn it in, it's going to tag it. Okay. All right. So that's that. Make sure, again, you follow the rubric. Make sure that you go in depth for each and every single bullet and you're good to go. Make sure your grammar mechanics is perfect. I don't want to see misspelled words. You can fix that. Okay. So write it in a Microsoft Word, do a spell check before you upload it. All right. Okay. And then after that, you have your quiz, I believe, 40 points, 2 attempts, and boom, you're done. All right. So that was that. That is everything you know, everything you need to know for this week. All right. Make sure tonight, it is Sunday now. Make sure tonight is the night where you finish your assignment, and I'm going to start grading tomorrow. And as always, I finish my grading by Wednesday. So please don't think that I'm ignoring you. If you haven't seen your grade by Tuesday night, I will get it done. I usually stay up late Monday and Tuesday nights to get everything done. Okay, because I do teach. Well, currently I'm at 7, I think. I don't even count anymore because I don't want to look. But some classes are more intense, labor intense than others. So just bear with me. I love teaching and I do love grading, but I am meticulous in reading everything. And so that's why it takes me a little bit longer. Okay. All right. So again, feel free to reach out in Canvas inbox right here anytime. And you got my cell phone. You could text me if something happens that is an emergency. That's about it. All right. Okay, I hope this video was useful and I'll talk to you later. Bye.